There hasn't been compelling news, really. It's on two things. One is de-escalation, and the other one is personalization or individualization or precising surgical approaches and so on. And this has been going on for years. It's just that we make more and more progress there. And this is always for both axilla and the breast. In the axilla, the de-escalation is the omission of radical surgery in patients with positive nodes, mostly by achieving complete pathologic response by neoadjuvant chemotherapy and determining that the nodes are clear without removing them all by targeted concepts such as targeted axillary dissection. This is all depending on neoadjuvant chemotherapy, the limitations there being that many of these patients would not need chemotherapy because they, just because they have a positive node, the luminal cancers, for example. So that's why in Taxis we come up with a design and a concept that is irrespective and not depending on neoadjuvant chemotherapy. And the other de-escalation aspect of the axilla is the omission of the sentinel procedure, which has been recommended in the Choosing Wisely campaign in the US for some time, and there is some confirmatory observational data. But the big two trials looking at this, also in younger patients, and asking the question if you can replace surgical axillary staging with just using, the ultrasound, are still ongoing, one in Germany and one in Italy. We still don't have those results. We expect them in the next few years, and as soon as we have them, this will change probably clinical practice in as much as we will not perform the sentinel anymore in many patients with clinically node-negative breast cancer. They will just receive imaging. So that's that for the axilla. We also have some de-escalation in the breast going on. We have some exciting de-escalation studies also after neoadjuvant chemotherapy, trying to reliably determine that there is pathologic complete response without surgery. Most of those studies are still on the stage where they perform the biopsy and then do still perform surgery and compare if the biopsy correctly predicted the result of the surgical specimen. But there is one or the other attempt to randomize after needle biopsy attempted confirmation of pathologic complete response. This is certainly where this field needs to move if it wants to achieve more progress and not so much focus on the endpoint of false negative rate of the needle biopsies, because we know we can leave some cancer behind for radiation that will follow after breast conserving treatment in the standard arm, and that would follow after omission of surgery also in these patients. So the question there will be how much or how little chemo-resistant residual disease can you leave behind for radiation, and not so much if the needle is able to, with 100% accuracy, predict where there is complete pathologic response. But it's also going in the way of de-escalation in the breast. That is just one exam that seems to be more mainstream compared to all the minimally invasive or non-invasive, even percutaneous ablation techniques that kind of seem to still be on the ablate and resect stage of clinical research. The other field, oncoplastic surgery, I've mentioned this. I've mentioned where we're going with this. The Oncoplastic Breast Consortium established leadership in this field in a very short time, and this is also now trying to get into the field of generating high-level evidence by performing those difficult randomized controls trials, now feasible by having these beautiful pragmatic trial design options that we haven't had before. So now these trials become more and more feasible and should be done. And oncoplastic surgery, and this will be my closing remark, is not really de-escalation. This is more personalization, because this also in many cases means an escalation of surgery toward bigger incisions, longer surgery to improve aesthetic outcomes and therewith, again, patients' quality of life.